Good afternoon, and welcome to the Wilmot Cancer Institute Community Conversations on Cancer series, sponsored by the Office of Community Outreach Engagement and its Community Cancer Action Council, or CCAC. I'm Sarah Merritt, the Regional Outreach Manager for the COE and liaison to the Access to Cancer Care Rural Integration CCAC Working Group. Thank you so much for joining us for today's community conversation on cancer, titled Hereditary Cancer Screening, What You Need to Know. Community Conversations on Cancer is an educational series designed to inform, educate, and disseminate best practices in cancer research, clinical care, and community engagement. Over the course of the series, topics will address the social determinants of health, improving cancer care delivery, and promoting health equity across the 27-county catchment area. This live event has been approved for one AMA PRA Category 1 credit, one CNE credit for nurses, and one contact hour for social workers. Our presentation will be followed by a Q&A session. Throughout the presentation, please feel free to enter any questions into the Q&A box at the bottom of your screen. Now, I am pleased to introduce your presenters, Ashley Hendershot and Ken Streb. Ashley Hendershot is a doctorally prepared nurse practitioner in the Hereditary Cancer Screening and Risk Reduction Program here at the Wilmot Cancer Institute at the University of Rochester. She received her doctoral degree from St. John Fisher College and presented her clinical scholarship on cancer survivorship and the role of longitudinal surveillance for those with increased risk for cancer. She also obtained her genetics and genomics certification from Stanford University in February of 2022. She has been with the Cancer Screening and Risk Reduction Program since 2019, where she works clinically as an expert in hereditary cancer genetics. Her research and quality improvement interests include increasing access for genetic testing, especially in individuals diagnosed with cancers where germline testing has the potential to inform treatment. Ken Streb is the Director of Strategic Business Analytics for Strong Memorial, Highland, and the regional hospitals that are a part of the University of Rochester. He has over 35 years of experience in healthcare finance. He is a lifelong resident of Monroe County and currently resides in Brockport. Ken is married with 3 children and 5 grandchildren. I will now turn it over to Ashley.
Thank you, Sarah. So I'm Ashley. I'm a nurse practitioner in the Hereditary Cancer Screening and Risk Reduction Program, and I'm very, very appreciative of getting to share this information today. It's what I do every day, and really grateful that we're able to talk about this. So a little bit about our program. We're comprised of medical doctors and nurse practitioners and a genetic counselor and a nurse who are we have clinical expertise in cancer genetics and the role of cancer genetic testing in health, and the role of family history in informing our risk for cancer. So when we talk about genetic testing, when we see patients, we refer to any sort of discussion about cancer genetics as a hereditary cancer risk assessment. So we assess someone's risk for cancer based on not just genetic testing, but their family history of cancer as well. So sometimes genetic testing may not even be recommended, but we still talk about what risk for cancers are based on your family history. And no matter what happens in that visit, whether or not genetic testing is pursued, we develop a personalized cancer screening plan for everyone we see. So this fun little picture down here is actually a picture of a genetic testing pedigree. We do pedigrees for everyone that comes into our clinic. And kind of come up with a plan based on that 3-generation pedigree of cancer. So that includes anyone's children, grandchildren, siblings, nieces, nephews, parents, aunts, uncles, first cousins, and grandparents. We also talk about recommendations for risk-reducing measures, and I'm going to talk a little bit about those at the end of this presentation. And we talk about risk reduction for people who have genetic risk, but also people who just have family history, and how even someone without a cancer family history could benefit from living a healthy lifestyle. And then what's most important is talking about families about risk for cancer. So one of the things that I get to say as a clinician is I don't just see patients, I see families. So a lot of times it's discussion of yes, John, you have this risk for cancer, but you need to tell your brother he needs to have this screening as well. Or maybe we recommend your relatives have genetic testing. So who should have a hereditary cancer risk assessment? We get a lot of messages from providers, from individuals asking this. And really, it's anyone interested in knowing the risk for cancer. Because again, they may or may not be eligible for genetic testing. We may recommend it. So anyone can meet with a genetics professional in our group. We review the cancer family history. We do that 3-generation pedigree. And then we make recommendations and counsel on genetic testing. And in that visit, we might recommend that someone pursue genetic testing, or we may say, you know what, maybe your mom should have it instead. But you should do this anyway. So whether or not genetic testing is performed, we talk about what strategies, what surveillance and what screenings are recommended. If genetic testing is performed, which I'm going to talk a little bit about genetic testing today, even if it's negative, we'll create a family history, recommendations for cancer screening based on that family history. And again, if positive, and we do identify that there is some genetic predisposition, we end up following with that patient to talk about a cancer risk surveillance plan, talk about how to get family tested. And typically we offer longitudinal surveillance to individuals who test positive. So we see them usually every year to talk about making sure they're getting the screenings and surveillance they need, as well as making sure that they're talking to their family about also getting tested. So what to know before a hereditary cancer risk assessment? One of the things that can be very burdensome is if someone comes into a visit without any information. So learning as much as you can prior to a visit in our program is really helpful, and really trying to get a detailed idea of what your cancer family history is. Recently, I saw an individual who he knew his grandfather had cancer. He had no idea what kind it was. He came to me because of a concerning finding on a colonoscopy. And we met a couple weeks later because I asked him to go find out what that was. And indeed, it was very, very concerning. So we ultimately pursued testing. But again, it's very helpful to have that information available. And getting as much as you can. So understanding what your country or region of origin is can be helpful. Relatives who have had cancer, I talked about that 3-generation being important. So getting as much of that information as you can. Where in the body that cancer started. So understanding whether or not that was a prostate cancer, a colon cancer, a breast cancer, and understanding how old they were when they were diagnosed. So younger ages of diagnosis are more of a red flag. And then knowing their age of death if they did die, and whether or not they died from cancer can be helpful. Knowing about your own history of colon polyps as well as your family history of colon polyps. And then knowing whether or not someone in your family has had genetic testing. So sometimes when people come, we'll say, well, did your mom have genetic testing? So and asking those questions ahead of the visit can be very helpful. So this is a screening tool that you can actually access online. This is a screening tool that we send out to all of our in-person patients to fill out prior to their visit. And it really has all of the pertinent information when we think about what information we want to see prior to an appointment to talk about whether or not genetic testing is recommended. But one of the things we say in cancer genetics all the time is that families are complicated. They're not wrong, they're not weird, they're just complicated. So some things can come up that can kind of put a hitch in our ability to know this information. Adoption, limited family structure. So not having a lot of relatives to draw information from. Contact, some people don't speak to family members. They don't have a relationship with them. Dynamics can be, different than other families. And then with the advent of commercial ancestry, we've had people find out that relatives were not actually their real parents or siblings, and finding newer relatives. So this is Alma Ancestry. This is a patient that has had all of these things. So this patient presents, she's 72 with breast cancer. She has 3 children. She's only had 2 brothers. Her mother, these lines mean she was adopted. So mom died young, so we don't know much about that, and we don't have any family history. Her father is passed. He only had brothers. She only has 1 first cousin on her father's side, and she doesn't talk to him. And then her grandmother left the family when her father was an infant and grandpa's deceased. So she doesn't have a lot of female relatives and she has breast cancer. So we don't have a lot of information. This is what we call a limited family structure. The other thing is this limited contact with relatives. She's not able to know whether or not there's cancers on that side. And the other thing that I noted here is that she has a half sister that she identified on 23andMe that she doesn't know and has no contact with, not even sure if she's alive. So these are things that come up in genetic testing that can make this information a little bit more complicated than, than some typical families where we see having a lot of that information available. So cancer genetic testing, one of the things that's really important to know is that all cancers are genetic. So there's cancer gene mutations in every cancer cell, but these are usually somatic mutations. They happen over the course of our lifetime. So if you look at this little guy in blue, that orange is a somatic mutation. He has one mutation, it hit over the course of his life from an exposure or some sort of DNA change. He did not inherit this. It rose over time. And when we test cancers for sporadic gene mutations, we call that genomic testing. So that's not genetic testing. So sometimes we have patients come in and say, well, I already had genetic testing. Typically, it's something that was ordered through oncology, and that's testing the tumor itself for those specific mutations. When we think about cancer genetic testing, we refer to it as germline testing. So that's looking at every cell in your body and whether or not you were born. So this orange, you were born with every cell in your body having this mutation present. And these are the ones that are inherited from our parents. And they make up about 10% of the cancers that are diagnosed. So we found that about 10% of cancers are indeed genetic. And again, these are gene mutations that can then be passed on to children. And what these pathogenic variants or gene mutations tell us is that someone has been born with increased risk for cancer. This person was not born with that increased risk. They just happened to have a sporadic cancer, whereas this person was born with that risk to develop cancer. So again, 10% of cancers are hereditary. Most, about 65%, are sporadic, meaning they happen because of exposures, lifetime DNA changes. But we still see these clusters of cancers that run in families. And this is one of the pie chart that we give to all patients that just kind of shows that most cancers are likely sporadic, 10% are hereditary, but that doesn't add up to 100%. We see this clustering of cancers in families, and the reason for that is believed to be resulting from shared exposures. So the best example I can give of that is if someone lived in a house, parents were smokers, they were exposed, and there's lung cancer in that family, that could account for that shared exposure. Other things, though, it could be other genetic causes not known at this time. So is there something genetic that just hasn't been identified yet that accounts for this? And there are things about genetics that we just don't understand, things that are inherited that we just don't know about at this point. So for that reason, we always use family history to inform recommendations for cancer surveillance. And that's also why it's so important to share personal and family history of cancer with our relatives, because it could, genetic testing could change down the road. They may be recommended to have more testing, but they could also be sitting with risk because of some of these genetic variables that we just don't understand. So what is genetic testing? So our genes come in pairs. We get one from our mom, one from our dad. Our chromosomes are made up of strands of DNA. They carry the genes that we inherit from our parents, and they make instructions for making proteins. And proteins are the things that help our body work normally. Some of these specific mutations can affect our risk for cancer because they might make these proteins not function. So a lot of these genes, these cancer genes that we're looking at, their role is to keep us from getting cancer. And if there are harmful changes within them, they might allow a tumor to form. So if you see this normal gene, we have a normal protein. If there's a mutated gene, we might have an abnormal protein, or maybe no protein is made at all. So when we do cancer genetic testing, we're looking for these harmful changes in the DNA that might increase the risk for cancer. And then from that, we can draw information. We know that certain cancers that gene is associated with and supposed to be protecting you from, we know you're at higher risk for those specific cancers. What cancer genetic testing does not do, it doesn't tell us that you have cancer. So that's one question we get is, I don't want to find out I have cancer. This isn't going to tell us you have cancer. It's only going to tell us about potential risk. It also doesn't tell us anything about your current cancer. It's not going to test the tumor for markers. That's that genomic testing that we talked about. That itself will help inform treatment decision-making for cancer. And it's not going to tell us that you're going to get cancer in the future. So some people walking around with genetic risk never develop a cancer. They're just at higher risk. They may never get cancer, but we are going to watch them more closely. So who should have genetic testing? In our clinic, most people meet criteria at this point for genetic testing, but the focus right now is on making sure that people with cancer have genetic testing, because it could certainly inform treatment decision-making. So we see that a lot in cancers like breast, ovarian, colon cancer, pancreatic cancer, prostate cancers, as well as some others now, but those are the big ones. But other cancers have significant hereditary link. So we see a lot of cancers run in families like uterine cancer, bladder, stomach, melanomas, and some of the rarer cancers that we diagnose. So anyone with a personal or family history of 2 or more relatives on the same side of their family, we always just say, come talk to us. We might recommend you have testing. Anyone with a family history of a very rare cancer, when we think about pancreatic, ovarian, male breast cancer, some of those paragangliomas, pheochromocytomas, any family history of young cancers. For example, anyone that's had a relative diagnosed with a colon or uterine cancer at under age 50, and anyone that has a significant number of colon polyps could also be at risk. But again, many individuals will meet NCCN or insurance criteria for genetic testing. One of the things we talk about is the importance of testing someone who can inform the family. So it's always best to have the affected individual, the person that has cancer, have genetic testing, because their results inform the family about their risk. So let's say that a patient comes in, she's 30, but her mom was diagnosed at 40 with breast cancer and mom's still alive. It would be best to test her mother, because her mother, if she's negative, that patient would not need genetic testing if that's the only cancer in the family. And that would also inform any siblings, any of mom's siblings as well. So mom is informing the rest of the family of whether or not they have a genetic risk. But in some cases, that's not possible. In some situations, there could again be those complicated family dynamics. Relatives refuse testing. I've seen it in cases where families have religious beliefs that don't align with that. So children opt to have testing because parents are opposed to it. The other thing is that those relatives may not be alive. So in my own personal family, my grandfather was diagnosed with pancreatic cancer, but he never had genetic testing prior to his death. So my mom had genetic testing. And my mom was negative, thankfully, but she informed risk for me and all of my siblings. So I'm one of 5. If my mom had refused testing, all 5 of us would have had to have it. So my mom informs us that we can't inherit something from her. So it's really helpful to try to have as informative testing as possible. If it's possible, we try to do that first. So some of the reasons when we talk about genetic testing, why to do it, is to really understand your risk for cancer. If you're at risk for other cancers, what screenings you need, are there surgeries that we should recommend to you? Are there medications you can take to reduce your risk? And then really focusing on some of those lifestyle risk reduction measures that I'm going to talk a little bit about at the end to help mitigate some of this risk. The other bigger reason is informing your family about their risk for cancer. So cancer genetics, these are autosomal dominant inherited genes. So if your parent is found to be positive, there's a 50% chance that you inherit that. So any patient that comes back positive, 50% chance their children and siblings also inherit that. So I like to look at case examples. Again, this is Susie. She opted for genetic testing because she was diagnosed with breast cancer at 55, and her mom died from pancreatic cancer at 73. She was found to have BRCA2. So this informed her, right? So she made a decision about her breast cancer because of this. She might have opted to have a prophylactic mastectomy as treatment for her breast cancer. She would probably have her ovaries removed because she's at risk for that. And she's also at risk for pancreatic cancer. So she's having more screenings for that. The other reason that it's helpful for her is she's now informed her family of their risk. So she's informed her children to get tested, her siblings, and her sister also tested positive. And we've learned that this did come from her mother because her father, who was alive, tested negative. So her mother passed that on to her. So this informs Susie of not just her risk for cancer, but also the risk for cancer for her children and siblings so that they can have the screenings and surveillance that they need. There are some downsides to genetic testing that we have to talk about and think about prior to proceeding. Again, the emotional burden that comes with knowledge. So it can be empowering, but it can also be very burdensome. Concern for your own health and knowing that there's risk for you and your family. And that's why genetic testing, having counseling ahead of time is so important. At most visits, two of the things we present is how will you feel if you know you carry risk and that your relatives may be at risk? But how will you feel if you don't know that information? And most people opt to say, I would rather know that information, take proactive steps for my health and know that. But for some people, having that information is not helpful. It's not beneficial. It doesn't give them any sort of information that feels good or gives them a sense of empowerment, and they opt not to have testing. So one of the things that we always mention is that genetic testing is a very personal decision. It's not right for everyone. And that's why genetic counseling is so important. Another limitation to genetic testing is the risk for finding things called uncertain variants. So sometimes we don't just get a straightforward positive or negative finding. We sometimes find these uncertain variations in the DNA. We found that the majority of them are benign. They don't cause any harm on our health. They don't have any sort of function that's bad. So when I talk about this, I use the gray analogy that if you read a book and someone misspelled G-R-E-Y for G-R-A-Y, the book is still read the same way. We get the same result at the end. But if that gray was spelled with an X, we have no idea what we're looking at there. So that could be harmful. So at this point, we just don't know if it's gray or gray versus GRXY. So more research and data collection is needed to understand that change. And for now, we treat it as though it's nothing and the lab is watching it. We'll let you know how that shakes out. But again, this is information that's kind of a question mark and leaves people going, well, what does it mean? And we just don't know at this point. Other limitations, we think about insurance coverage. There is a federal law called GINA. It's the Genetic Information and Non-Discrimination Act. It does prevent your employer and your insurer from using genetic information against you to deny coverage. GINA, unfortunately, does not protect in New York State. It does in some states, but not in New York State. It does not cover long-term care insurance, life insurance, or disability insurance. Now, in most cases, for people who have cancer, that information isn't very important, and they're not going to get a life insurance policy changed at this point anyway. But for someone who tests positive when their children come to have testing and there's a 50% chance they inherit, or for someone who doesn't have cancer when they come to do this, we do say if you want those policies, you might want to get those in place before you have genetic testing. It won't influence a current existing policy. It's only if you went to apply for that and that insurance company got a hold of some of your medical information. Cost of testing is also a concern. I will say most insurers who align with the guidelines, we don't see many times where it's completely denied. Most insurances cover if you meet eligibility and criteria. But there's two pieces to genetic testing. So it's your counseling visit and genetic testing cost. So for counseling visit, it's just a specialty fee, co-insurance, deductibles, co-pays, all those things apply. As for the cost of genetic testing, this has become more of a standard, there is out-of-pocket options for testing at this point. Most people don't pay anything if they meet criteria and they don't have a high deductible plan. But for those with high deductible plans or people who have who don't meet criteria but just want to know this information, the genetic testing companies will offer a cash price to not run it through insurance, not exceeding $250, and that can be paid for with an HSA. So these are options that are available for people who have these high deductible plans or don't meet criteria. But I also want to end talking about what to do with risk in general, how to reduce your risk for cancer overall. So this is the conversation we have with people whether or not they test positive. And again, some of these things might change based on family history. But one of the most important things you can do to reduce your risk for cancer is to have your routine cancer screenings. Mammogram at age 40 and colonoscopy by age 45. Again, we might recommend those things earlier or more frequently based on the family history and genetic testing. We might also recommend other screenings. So it's really important to just kind of have an idea of general population screenings and getting those screenings that are recommended to you. If you smoke, work on cutting back. That's the first step with the goal of quitting. We have a lot of great resources in our area. We have the New York State Quits Line. We also have a great smoking cessation clinic for anyone seen in our clinic. The oncology, there is a nurse practitioner named Patty Maliber who sees a lot of our patients to talk about smoking cessation, and she's actually certified to give medications and talk through that. Moderation of alcohol intake. There's a goal of less than 3 drinks weekly. So I talked to patients who really like alcohol about just cutting back, trying to shoot for 3 to 5, and then maybe moderating from there. Some of the more recent guidelines from cancer risk studies that are coming out are actually saying that no alcohol is better for your overall health. But I understand that life is about living as well. So we talk a lot about moderation. Exercise is really important. So no matter the person, increasing activity is really what people should be trying to do. So reducing their time spent sedentary. Several studies have shown that people who have more sedentary occupations or work at jobs where they're sitting at desks longer actually have higher risk for certain cancer types. So really just get moving, get walking around. Standing desks are great options. And you don't have to be vigorously active, right? You don't have to be, doing HIIT workouts. Just being more active, walking, and just being more active outside during the summertime. Those are great ways to increase activity. Eating a nutritious intake of food. We focus a lot on the plant-based Mediterranean diet. So getting foods that are nutritious, less processed foods, eating more fruits, plants, seeds, nuts, vegetables. Eating a high fiber diet, the guidelines say you should be getting 25 to 30 grams every day in your diet. If you sit down and write that down, I dare you to tell me that you get that much. Fiber is something that's lacking in our American diet and actually increases risk for colon cancer and perhaps other cancers. Moderation or limiting red meat is also very, very important and worth doing. There's some data about increased red meat, some of those mutagens from cooking and things like that could increase risk, especially in colon cancer and GI related cancers. Wearing sunscreen. In our area, there is quite a melanoma risk, even though we don't get what we think, we don't get a lot of sun. Covering your skin as much as possible. So those areas that you can't reach, your scalp, things like that with hats. Using SPF 30 or higher and limiting your UV exposure. For women, really important to perform self-breast exams or be self-breast aware, noticing any changes in your breast tissue. And also the importance of reporting unexplained weight loss or unusual symptoms. So sometimes when I'm talking to patients, I always say, you should let someone know. For women who are postmenopausal, report any bleeding that's unexpected, reporting bloating, changes in bowel habits, things like that. It's very important to promptly share that information with your medical providers. But in summary, about 10% of diagnosed cancers that we see are hereditary. And again, some cancers are more likely to be hereditary than others, but I will say that since starting in 2019, we're finding out about more connections and more cancer risks that could be associated as more people are having genetic testing. You see me smiling because this is very exciting, and it's going to really change over time. And we're going to find about more of these how we're going to map some of these cancers and really help people inform their risk prior to hopefully ever being diagnosed. Our NCCN guidelines, which are what we use in cancer, those guidelines for genetic testing, they're constantly changing. More and more people are meeting eligibility for genetic testing. And again, as we learn more and more, as more people test, we're going to learn more about those connections. The screenings and recommendations for those with hereditary risk, so the people that we see who we talk to every year about, you have BRCA or you have Lynch syndrome. Some of these risk reduction strategies are constantly changing as we learn more and more data is collected. And this could lead to possible future treatments that we just can't even imagine at this point. Gene therapy is the one I get asked most about, and we've actually had some data coming out about gene therapy that sounds very promising. So that's always something that we look forward to, hopefully in the nearer future. And again, everyone can reduce their risk for cancer just by living a healthy lifestyle and doing some of those risk reducing measures. So if you ever have questions, we're happy to see you in our program just to talk through that with your family history. May or may not do genetic testing, but again, cancer, we're hoping, will be preventable and treatable, and we'll prevent people from ever developing cancer with some of this information. So I thank you for your time. I'm going to pass this over to Ken, and he's going to talk a little bit about his own experience with genetic testing.
Good afternoon. As was mentioned at the beginning, I've worked at Strong Memorial and Highland Hospitals for the past 35 years, been in healthcare finance. The question I was asked to follow up on here was how I heard about cancer screening and genetic screening. My story probably goes way back. In the late 1980s, I had a GI issue that required me to get a colonoscopy. The gastroenterologist at the time thought I might have Crohn's disease, so he recommended a follow-up colonoscopy. In that follow-up colonoscopy, everything was fine. There was no issue. He felt that it was a one-time issue for me in the late 80s, and everything was fine. This is something that obviously is a concern. I waited 25 years before I had the next colonoscopy. I'm sure if there are gastroenterologists in the audience, you're probably gasping right now. Basically, I waited because I was raising a family, taking care of ill parents and in-laws, and a whole lot of other things in my life. My attitude was, well, the one in early 90s came out perfectly, so what do I need to do for it? Why do I need to do it? And my attitude was, I don't need to do it at this time in my life. It kind of got on the bottom of my list. What happened in 2016, my primary care doctor sent me a letter saying, you're way overdue for your colonoscopy. You should get one. That really got me thinking that I really needed to do it. And even with that, I never got the first one until 2017, a year later. In 2017, I had a colonoscopy. That colonoscopy revealed about 11 polyps that needed to be removed. All of them were benign. But the gastroenterologist from Strong, Dr. Yoon, recommended that I have another colonoscopy within a year. That second colonoscopy revealed additional polyps that I had, totaling between the two enough to allow me to get genetic testing. I did that in 2019, and as a result, I followed up with Carol Lustig from the genetic testing program, or Hereditary Cancer Screening Program, and followed up, got the genetic testing, and went through that. And Carol went through the results of the screening and provided me with a plan for what I should do in the future. Another question I was asked, what was the process like? Well, the colonoscopies, of course, are a pain to do, especially the day of preparation. Reviewing the results and anticipating the results was certainly anxiety-provoking. Besides that, the process was very easy. It was a simple blood draw for the genetic testing. And besides the colonoscopies and the anxiety, everything was relatively easy. Would I recommend this to others? Absolutely. It's important to know whether you have a genetic disease or not. Even if you don't, and in my case where you have a lot of polyps, you need to know what to do with that going forward and how you should proceed. So I think it's critical for everyone to look at genetic testing if you have indicators that it's needed. And of course, everyone shouldn't wait 25 years till they get a colonoscopy. A couple other items I wanted to review. With my 35 years of experience in healthcare finance, I have to bring this up. The cost of the genetic testing is, Ashley indicated, there might be more coverage on that now. When I look back at my test, the cost of it was $2,200. I was in my deductible phase, or my coinsurance and deductible had been met. My expenses were only $500. But if you think of others who are perhaps not well off, those on the poverty line and so forth, you need to think about, well, how would they get to get genetic screenings? Remember, likely, at least for certain diseases, you're going to need to have a colonoscopy, perhaps 2 colonoscopies and other testing. So you have to think that some of those patients are going to have to pay for a lot in addition to the genetic testing. What I want to let everybody know is that Strong and Highland, and I'm sure the other system in the region, all have financial assistance policies. This provides for a write-off of certain expenses, and it's a sliding scale based on income. If anyone needs information on that, at a separate time, I'd be happy to get together and talk to you about it and let you know about the details. So a couple other things to discuss. I'd like to ask in the Q&A session, on the TV, you'll hear a lot about Cologuards. And I don't know if those are okay or not. It'd be interesting to know. And one other anecdote that I found out throughout this whole process, what I needed to do was a PSA screening. When I did that, my PSA came out above the range. And on the way out of the office, when I talked to the urologist, I asked him if there was something I could do to improve my PSA. In the conversation, he mentioned something about cycling. And once he mentioned that, I turned around and said, oh my goodness, before the day when the draw was done for the PSA screening, I had gone bicycling for about 15 miles. And he said, yes, that would affect your PSA screening. So what I did is I went through and spent 4 or 5 days without doing that, came back for the PSA screening, and my result was fine. Part of what the urologist recommended initially was that I may need a biopsy. By following up on this, I realized I didn't need a biopsy. And if you think about it, I don't know a lot of people who are out there who would really understand that cycling could affect your PSA. It's just another thing that came out as the results of doing genetic testing. Thank you for all the spending the time to go over this.
Thank you so much, Ashley and Mr. Straub, for this fantastic presentation. We will now open up to our question portion. As a reminder, please enter any questions you have in the Q&A box at the bottom of your screen. If you would like to ask a question to a specific person, please just note that and name them in your question. All right, so I will go through these questions. We have quite a few of them. So our first question is from Wendy. She states, my mother had breast cancer and she was told she had a rare gene and her family should be tested. When I called to get the test, I was told that each family member had to pay $150 in order to get the test. Are there any programs that would help cover that cost?
So that I can't speak to. So usually with the genetic testing companies, $150, it's usually $100 to $150 for single site testing. And that would be for someone who had like a high deductible. And typically a lot of these genetic testing companies do offer financial assistance. My other thought is, come chat with us if you haven't already so that we can kind of strategize other ideas as well to think about genetic testing. But I will know if that was the amount that was was told to you when you reached out or had genetic counseling. It could be just what was expected. But I do urge anyone that had questions about that. There is a financial assistance program through all of the genetic testing companies we use. They don't get taken advantage of enough. So definitely go that route as well. Because it's not a bill through the University of Rochester, these are companies outside. We don't really have control over managing that. But again, those financial assistance programs with the 3 testing companies that I use, those are available.
Awesome.
In addition, one thing I didn't mention about the financial assistance policy here at Strong and Highland is that people think financial assistance and they think, well, it's only for self-pay patients. We also offer it for co-pays and deductibles. And again, if anybody needs to find more information on it, they can call me. I'd be glad to go through that with them.
Great. Thank you. Thank you for that insight. All right, move on to our second question. I think, Ashley, this might be for you. What is being done? Is there an effort being done to diversify the hereditary screening team here at Strong?
So we have a pretty diverse group. I would say we're kind of the team we have that have applied to the program. Dr. Talis just joined our group from Israel. But again, when we first started this program in 2019, it was Carol and I. So we've kind of got people interested and joined along as we went. But that is something that's on our radar and something we're interested in growing is the diversification of our group. And we're actively growing. So that will definitely be a part of our, what we're going to do moving forward.
Great. Yeah, this team has come so far in just a short amount of time. It's remarkable. All right. And third question. So the first, Ashley, I'm going to ask you to kind of state this in plain language for those of us who don't know these scientific terms, but can repeated sporadic mutation down a few generations lead to germline mutation subsequently?
Okay, so that's tricky. So sporadic mutations are typically theorized during the course of our lifetime. I will say, and this is going to be very high level, but there are epigenetic changes that can be sporadic that we think might be inheritable. So to put this in a way that might be understood is our DNA is like our sheet music, right? Like it tells us how to play the instrument for anyone that knows how to play an instrument. Our epigenetics might be the DePoco or things above that are telling that music how to play. We don't know enough about those yet to know, how much they're inherited, but we do believe there is data about that. So that's a great question. My answer is maybe. But in terms of just for general knowledge, just because your mom developed a sporadic breast cancer doesn't mean that you're going to inherit. But there are other things on the radar that could be contributing to that could potentially be putting someone at risk, which is why the family history itself trumps any other genetic or any other information, even if genetics are negative.
Okay, thank you. All right, next question. Is there a correlation between tumor or node size and weight?
Absolutely. So we do know, I recently did a presentation on breast cancer. Weight is definitely something we tend to find people with breast cancers who are overweight, they have worse outcomes. And they're found with later advanced disease. So that could certainly play a significant role when we think about some of the cancers. And we know that obesity, adiposity, having a high body weight can also contribute to risk for cancer. So again, healthy weight is another thing to consider.
Okay. All right. Let's see here. Do you know of any advocacy to prevent genetic testing from affecting life insurance?
That's a great question. So my colleague Megan is actually, she's written a couple of commentaries about GINA and its lack of protection. One thing is there is some advocacy. I'm not sure what's happening in New York State, but in 2019, Florida, under the radar during COVID, actually passed a law to protect life insurance as it related to GINA. So this bill has been kind of going around in other states and trying to find more protections in other states. Unfortunately, I haven't heard much about what's happening in New York State. There was a white paper about this back in, I think, 2019, but it kind of has gone by the wayside. But I urge you to look out and talk to your legislators about that if you're interested and think that's definitely something that's a passion of ours as well. As I keep telling patients, I hope we follow suit behind Florida in that regard, because if we had this protection, it would certainly get more people to have the testing they need.
Great. All right. How often does genetic testing lead to radical preventative procedures like the double mastectomy that Angelina Jolie famously had? And when are those decisions recommended?
So I will say from risk, looking at this risk, things have changed a little bit. So we have this, we call it the Angelina Jolie effect, where people came out and were getting tested and doing a lot of preventative surgeries. If someone does have increased risk for ovarian cancer, there's no good screening for ovarian cancer. So we do recommend that ovaries be removed. I don't have a better recommendation than that. As close to menopause as we can get, but that is typically a recommendation. When we see bilateral prophylactic mastectomies, one thing that has come out recently was the American, the breast surgeons in the country kind of came together about consensus on what women should do who had risk. And they actually found that women who carried BRCA mutations and had breast cancer should still be offered to save their breasts. And that's because we have really good imaging for breast cancer, right? We have breast MRIs, we have mammograms, we have ultrasounds. These are very sensitive, specific. We can catch breast cancers early and do something about them. And what that information also found was that women who pursued prophylactic mastectomy, they didn't live longer because they had a mastectomy. It's the psychosocial benefit. So it's that you're not going to get a cancer. You don't have to go for screenings anymore. You don't get what we like to call in cancer genetics scanxiety, where you're sitting waiting for results. You never have to have breast imaging again after a prophylactic mastectomy. So the benefit for mastectomy is knowing you're never going to get it again. It's that peace of mind, sense of well-being. So it used to be that most women that tested positive and had risk for breast cancer would just go and have surgery. But we've seen that kind of, based on this new information, we present it both ways. I call it the choose your own adventure, and that can change anytime. The only thing we can't take back is if you've had surgery, we can't get that back. So we counsel about all the options when someone does have an elevated risk for breast cancer.
Oh, thank you. All right. What does a score of 29.9 mean for breast cancer DNA screening?
That I'm not sure. So if that was a commercial DNA test, I would say I wouldn't invest much thought into anything that came from a commercial lab when it relates to cancer risk. Their data is not, it's not evidence-based. I would urge you to actually, if you're thinking about breast cancer risk, I would urge you to talk to your primary care provider or come see us. There are risk model calculators that we use that actually give us a very informed percentage lifetime risk for breast cancer. One of those scores that we use is something called a Tyrer-Cuzick. And you can get that score back on a mammogram. You might see that report on your mammogram because our breast imaging center calculates one automatically for a woman at their mammogram. And what that does is it gives us a lifetime percentage of what your risk for breast cancer is. And for anyone whose lifetime risk is over 20%, typically we recommend that you have enhanced breast imaging so that you be offered a breast MRI in addition to your mammogram every year.
Okay, thank you. All right, next question. My family is from the South and my mother died when she was 6 years old, and it's hard to find out about family history. But on her dad's side, they had good health. So what should I do about cancer screening and testing?
So I think getting as much information as possible is helpful. For you, if something like just talking to someone is helpful, we could talk through some of the things and look at your lifetime, you know, if you're female, your lifetime estrogen exposure, and looking at things like that to come up with a plan for breast cancer screening. For males, talking about starting colonoscopies for men and women at 45. The other thing is you could pursue genetic testing if it brought you a sense of, you know, you wanted to have that information. You may not meet those criteria, but again, there are out-of-pocket costs available for genetic testing if it felt like something that were helpful. And again, the bottom line is a healthy living, living a healthy lifestyle, doing all those things to reduce your risk for cancer are also very, very important.
Okay, thank you. All right, we have one for Ken here. How long was it before you received your genetic testing results?
I received them pretty quick. I think it was about a month from the day of the blood draw.
Okay, great. All right, next one. My wife had uterine cancer, and the provider said that they did a genetic test on the tissue. Is that common practice for such tissue samples?
Yeah, so when we do tumor testing on cancer cells, that is to do precision oncology. So when we look at the tumor, we look at the mutations in that tumor, and oncology is looking to find the medication that will target those specific mutations. So we see cancer genetic testing in several cancer types, and that's just to help us inform how to treat that cancer appropriately.
You know, I actually have my results in front of me, and it took me exactly 9 days.
Oh, wow.
So it was pretty quick.
That's great. Okay, moving on. So we have a couple more. Is there a correlation of obesity and weight with cancer due to obvious or visible tumors on screening procedures, while patients without obesity may go undetected, or is it truly due to weight or obesity?
So that's not well understood. There's some thoughts behind obesity and cancer risk. We're not sure that maybe leptin and some of those other things that go, so high levels of insulin in our body, because as a result of a high intake of carbohydrates, are some of those things feeding cancers. And I think if you spoke to a nutritionist, they would say there's a good chance it does. So that could be a component of it. The other thing is it could be missed, right? So when you think about a body habitus, things like ovarian cancer, those are hard to, the signs and symptoms of an ovarian cancer are bloating. And, the only screening we have for that is bimanual pelvic exams. And when someone has a large body habitus, that's hard to feel. And so a lot of times cancers may go undetected for a longer period of time. Breast cancers may be harder to see if someone has, when someone has fattier breast tissue, it's easier to see through it on mammogram. But again, there is that chance that we miss something. So that's a great question. We can probably attribute it to both.
Okay. All right, going back to those genetic results, Ken and Ashley, what do genetic results include? So when you get that back, what are you looking at?
Cancer genes, that's it. So one of the things I always say at the end of every counseling visit is we're only looking at cancer genes, and we do multi-gene cancer panel testing. So unless we know the cause of cancer in your family and are going to single site test someone, we look at a bunch of genes, and that's so we don't miss something that have implications. But what we're not doing, we're not looking at medical genetics. If you have, autoimmune disorders or dementia, things like that, or cardiac even, that goes to medical genetics. So it's only for cancer genes. The information is only used to look at cancer genes. They don't share this information with anyone else. And they're not going to find your ancestors or anything else using this information. It's very, very private.
And for what I had on the results that I got, it mentioned some of the diseases that they're looking for or genetic issues that they're looking for. And honestly, most of the rest of it, I really have to ask Ashley how to interpret most of it. But there's a whole lot of, scientific information in here. But, basically at the time, Carol went through the results.
Okay, thank you. All right, if breast cancer runs in a family, should both men and women check for it?
So there's no data about male risk with breast cancer. The only time we see increased risk for male breast cancer is in the setting of some germline mutations. So BRCA2 is one of those. The other thing is things like Klinefelter syndrome. So in men who have been exposed to more maybe estrogen than those assigned female at birth are.
Okay, and does prostate cancer run in other men in the family? Is that one of the?
Sure is. Yeah, so we see all the time. We've been doing more testing in genetics for prostate cancer, but many times it's negative. Prostate cancer to me is very similar to breast cancer. I think there's other genetic link that we just aren't well understood, that aren't genetics we know to this time. So we have clustering of prostate cancers in families. And it is more common in those of, that are African-American, have African-American ancestry. So anyone that has even a father, brother, grandparent, we recommend at least 10 years prior to that diagnosis, they begin having prostate cancer screening. And that screening, I urge you to have both a prostate specific antigen, so the blood draw, but the recommendations do say that you should also have a digital rectal exam yearly. So both of those things together.
Okay. All right, and the last comment here is from Holly Anderson. She says, great presentation, Ashley. Interesting background on Gina. This bill was first introduced in Congress by the late Congresswoman Louise Slaughter. Though the Breast Cancer Coalition of Rochester fought for a stronger bill, one that would protect against genetic discrimination for life or long-term care insurance, we were proud of Louise's efforts. She was an outstanding advocate for cancer patients in general. Nice tie back here to Rochester. All right. Well, I'd like to thank both our presenters, Ken and Ashley. Thank you so much for this fantastic presentation. I'd also like to thank the interpreters for helping make this accessible to our deaf community. Please be sure to fill out the survey following the webinar. So we are making sure that we provide the content that is interesting to you and that you're interested in hearing about. This webinar has been recorded, and an email link with a link to the video will be sent to all registrants early next week. Any questions that we're unable to get answered will be answered in this email as well. And please join us for our next community conversation on April 20th at 12 p.m. Thank you so much.
Thank
Thanks.
you.